That's very good. Most people will use their lips to hold the tongue up like that, but
I've seen that done before.
have you?
That's
You have seen that done before. You've been
You guys were
practicing?
rolling.
Yeah.
Oh, sorry. Here we are again in the middle of our little exercises. Hi, my name is Shirley Gutkowski, and this is The Spot for Health, where Sun Prairie goes to learn about places to go and ways to get healthy. Today I have a very special guest. He is a dentist from Oregon, from Baraboo. I don't know where Oregon came from. From Baraboo, the complete opposite direction. And his name is Dr. Mark Paschen. He's been practicing dentistry for 30 years in his practice on focusing on orthodontics, TMJ treatments, and treating patients for sleep-disordered breathing. He believes in early interceptive treatment for his patients. He realizes that many problems can be avoided treating children while they're still growing. Yay! And Dr. Paschen knows young bodies have great capacity to adapt to treatment, as he has been treating children as young as 4 years of age, really, for orthodontic. That's pretty awesome. So his Baraboo practice is an airway-focused practice, and his philosophy is non-extraction, my favorite kind.
You bet. You bet.
So when you say non-extraction, you're talking about permanent teeth.
Permanent teeth.
Right.
Correct.
Yeah, because that still seems to be a little bit popular.
It is, and I'd have to say, Shirley, in the 30-plus years I've been practicing, I can count on one hand the cases I've actually had to remove teeth, permanent teeth. It just doesn't have to be done nowadays.
I agree with that. I'm not an orthodontist, but I have seen the after effects of that kind of treatment. So how young do you see children in your practice, or how young are people referred to your practice?
Well, as you had said, the youngest person that I actually treated was 4 years old. This person had what's called an anterior crossbite. That is when the lower teeth are in front of the upper teeth.
Okay.
And if you do not treat those at a young age, what you're looking at is future surgery.
So that's sometimes called an underbite.
An underbite, correct. I would recommend, though, if parents could, depending on the maturity level of the child, even as young as 1 or 2 years old, isn't a bad idea to take them to the dentist, and especially if the dentist is versed in looking for airway problems, those types of things, have the dentist look for that stuff so they can at least prep the parents. Possibly the child isn't mature enough to actually do treatment on, but at least be able to monitor the child until they are mature enough to do the treatment.
How does a parent know that it's an airway practice? I mean, that's not a very common term.
Not a real common term. What they should do is call their dentist and ask the receptionist, does your dentist take any courses on airway or on sleep breathing disorders? Do you have the capability to evaluate tonsils and adenoids in your practice? Those types of questions are really good ones.
Yeah, I think that's a good point, because this airway-focused practice term is kind of new.
Very new.
Yeah.
Very new. It used to be, orthodontics in the past was basically you'd wait until all the permanent teeth would come in, and then you start pulling the permanent teeth. Fortunately, we don't do that anymore, or most of us don't do that anymore. Instead, we want to guide the growth. The ideal time to really see the children, the American Association of Orthodontists recommends as young as 6 or 7 years old, because at that point the children are still growing. And we can put in all different kinds of, we have little expanders.
Yeah, you have little appliances here.
Yeah, little appliances that are very small, as you can see, just a little bit of wire here on the appliance that we can very slowly manipulate the growth and get the arch form to be where it should actually be.
So when we were talking the other day, we came upon the term compliance. And so there are a lot of appliances that you can put and glue into the mouth, right? And then that's what you're showing us here.
Correct.
And then there are some appliances that are like, I don't know, silicone, let's say, that children should use an hour a day or so. And you had some really good points about the compliance part and how the glued in, what do you call it, cemented
Exactly, the cemented appliances.
Yeah.
Exactly. There are some excellent, excellent training aids that patients can use in order to be able to, again, guide their growth. A lot of these are removable, and it really takes the parent's full cooperation along with the child to make this work. And in our busy day and age, it's very difficult to get a parent to spend an hour or two a day with their child, or to monitor the child even to make sure that they're wearing the appliance. For that reason, I have basically gone all fixed appliances, all cemented appliances in my practice, because it's just very difficult to get the kids sometimes to cooperate with this. If you have a cooperative kid, ideally you do use a removable appliance. It would be wonderful.
Those are very small, and I really like that because they're easy to clean and they're not really obtrusive with respect to a toothbrush.
Oh, not at all.
Yeah.
And we give all our patients, when they have a fixed appliance in there that has any problem as far as the hygiene taken care of, we automatically give them a water pick, or you know, most dentists will do that are treating kids with these appliances.
So how do you determine if a kid needs an early appliance, or a child? I'm trying to not say kid.
Sure, yeah, a child, very good. I made that mistake also. I have a couple of different criteria that I use in my office, Shirley, as far as determining when a child needs early treatment. One big one is whether they have room for all their permanent teeth in their mouth. Now, there's a panoramic x-ray that I believe Mara will put on the screen here, and that panoramic x-ray will show pretty much all the permanent teeth with the exception of a couple lower teeth. And the one on the lower right side is something called ankylosed.
The one with the green arrow.
The one with the green arrow. And that ankylosed tooth is when a permanent tooth erupts up, instead of the baby tooth coming out of the mouth, that baby tooth sucks back into the jaw. And there's no way that that baby tooth, or primary tooth as we call them, will come out on its own. So you have to have early intervention and get that tooth out of there in order for normal growth to take place. But if there isn't room for all the permanent teeth, you need to create the room. And again, like I said in the past, they would let everything try to come in and start pulling teeth. Now we use these types of appliances, work great.
So you're making room for all of the permanent teeth with the mindset that you don't get extra teeth. It's very uncommon to get extra teeth.
Exactly, and there again, by taking that panoramic x-ray, we can see whether there are extra teeth in there. And then we plan accordingly, you know, when and if those extra teeth have to be removed. So that's one criteria, the creating room for the teeth. Another criteria that we use is if there's a really bad skeletal problem, which means a crossbite. For example, if we have, like I had alluded to earlier, an anterior crossbite or underbite, we need to treat that immediately. Depending on the child, if they're able to, as we feel, handle something like the appliances. And we also use, along with this, we can use something, it's called a face mask, not to be confused with headgear.
Right.
I've been
It's
doing
completely the opposite, right?
Completely opposite.
Yeah.
I've been doing orthodontics for over 32 years, actually. I have not used headgear on one child in my practice. What the headgear does is it's retraction orthodontics, pulling things up and back, which we don't want to do. We want to keep everything moved forward. That's what this does. It's not worn at school like sometimes the headgear was supposed to be worn. It's worn strictly at home and at night to sleep. Works wonderfully. What it does is it develops the midface of the children who are deficient, which again helps the airway by moving things forward, and it gently puts a little force on the chin to keep that chin from growing forward anymore.
So sometimes I'm asked why we have so much snoring and why so many people are snoring and why this airway thing is an airway thing. And can we, well, let's say it, that sometimes the retraction kind of orthodontics where everything is pushed backward is impacting the airway.
100% yes.
Okay.
And I know that there will be people that argue that when you remove teeth, you're not retracting. And that may be true. However, I look at it a lot of times it's been misdiagnosed as they needed things moved forward in the first place. So they're already retruded. If you don't retrude anymore, sure, that's okay, but they're already retruded. So move them forward, get the airway opened up, and they're much better off. I've had patients that we put the expanders in and they've stopped snoring. Simply by, once you expand out, as you're moving the palate across, the roof of the mouth is the floor of the floor of the sinuses, right. And so the sinus will drop and they have more airway in.
I read a study last year, and maybe the study was already a year old, about this kind of an arch expansion appliance and how kids that are having this appliance treatment stop bedwetting.
Yes.
So
yeah,
that was like bing to me.
To me, yeah, and that's one of the symptoms that I have the adults look for, the parents look for. If they feel that they have a bedwetting child, what we do is if we can get the tongue to function properly, get the patients to breathe properly, and not mouth breathe, a lot of times the bedwetting stops. And this is why, is if you're breathing through your mouth, you're losing a lot of carbon dioxide. And carbon dioxide is what really helps to regulate the breathing process. And so the body doesn't want to lose that carbon dioxide, so what it does is it contracts the smooth muscles, which are like the arteries, the veins, all the smooth muscles that's holding the carbon dioxide. Well, the bladder is a smooth muscle. So the body will contract the bladder along with the blood vessels, and kids are so sound asleep they can't wake up to go to the bathroom, so they wet their bed due to this bladder contraction due to mouth breathing.
So that's the smooth muscle story that you just relayed also works for adults with high blood pressure, because now they're breathing with their mouth open. The smooth muscle is the cardiovascular system, as you just said, and so that's another symptom of, well, it's another outcome of snoring, I guess.
Exactly, snoring and sleep apnea. A lot of the adults that they say, oh, I get up 2 or 3 times a night to go to the bathroom, they actually have sleep apnea and they're not even aware of it.
Yeah, it's a tricky little thing. It's amazing how many things start in the airway. How many different conditions will start in the airway. So let's just stick. We could
go way off. Well, another thing I look for, I know we were talking about things I look for treating early, early children.
Yeah.
Well, we talked about if there isn't room for the permanent teeth. And another real important thing that I look for if there isn't, I look for the airway. There's a cephalometric film that Mara will put up that we get a really good idea of what the airway looks like.
Yeah.
And we can look at this film, and that's another thing you can ask your dentist, do they have the capability for this film? The only other way to look at the adenoids is to have a scope go in through the child's nose. Obviously, that's
like
pretty
fun.
Invasive. Cephalometric film is totally non-invasive, very easy, just like conventional digital image. And we can see the size of the adenoids, we can see where the tonsils are, we can see the arrow there, it's called the hyoid bone. The tongue attaches to that near the hyoid bone, and we could get an idea if the tongue is too far back, too far forward. There's a certain distance the hyoid bone should be from the mandible, for example. And we can diagnose all of those types of things, and if we detect a breathing issue, a lot of times I'll have them go, someone like you, get them breathing properly, Shirley, and get the tongue position in the correct spot, and they won't even need this early treatment. Yeah,
it's amazing how important the tongue is and how manipulating the tongue to act in a precise way can open up that airway and just solve developmental problems. We were talking, I was talking earlier today about ADHD and sleep apnea and childhood snoring and the relationship between those two things.
Exactly. A lot of times children are diagnosed with ADHD and it could actually be a sleeping problem, because they have shown that children who are very sleepy act out as being hyperactive during the day. And whereas when adults are sleepy, they don't get enough sleep, they're tired.
Right. They take a nap.
They take a nap.
They know they're tired. They might not they might feel snappish, but maybe they'll just curb it a little bit.
Exactly, whereas the kids don't hide it.
No.
They're tired, well, they're hyperactive, and that's one thing. We'll get to some of the signs that parents should look for with breathing problems. One of the big ones is if the child's teacher is calling you at home and saying, Johnny is disruptive to class, Johnny's always talking out in class, he's interrupting, very hyperactive, he can't concentrate on anything.
Yeah.
It may not be ADHD. It could simply be that Johnny is not sleeping well at night. And it's interesting because I guess one of the theories behind the treatment for ADHD is Ritalin. Okay, so what is Ritalin? It's speed.
It's a
It's
stimulant,
so you
yep.
think if somebody is hyperactive and you give them speed, they'd be more hyperactive. It would make sense. So the theory is that these kids are actually very tired. So they're hyperactive but tired physiologically, so they're giving them speed. The speed of Ritalin is waking them up, so to speak, and they get to the point physiologically where their bodies are awake and they reach kind of a homeostasis, so they act out normally. They don't have that hyperactivity anymore.
It's crazy.
I mean, it's really crazy.
And it all could be avoided by sleep. So what are some of the other symptoms of breathing problems that you're seeing? So ADHD is pretty far along already. So what are earlier
ADHD,
symptoms?
and they've actually shown, Shirley, that if somebody has ADHD and it goes kind of untreated, they follow these children, or even breathing problems, they can lead to one or the other.
Yeah.
The ADHD kids can wind up with sleep apnea, and the sleep apnea children can wind up with ADHD. It's just a really bad circle. Some of the obvious things that adults should look for with their children with sleeping problems: do they snore? It seems just so obvious, and just because children snore doesn't necessarily mean they have sleep apnea. And it doesn't necessarily mean they should be treated either, because a lot of times we'll have the tonsils and adenoids removed and the snoring will continue. But what you have to look for is the snoring getting worse? Are they gasping for air at night? That type of thing. Are they coughing a lot at night? Are they sweating a lot at night? And as the children reach adolescence, their tonsils and adenoids tend to shrink anyway, so a lot of times the snoring goes away. And that's okay. Usually it doesn't cause any problems, but if you have an adolescent even that's snoring, you really need to get it checked out. Snoring is really not normal at any age.
So let's talk about that with the adolescents for just a second, because the tonsils do and adenoids do shrink after like age 8 or so, and then the snoring may abate and it might not be as noisy. But during that time, the child may have developed a behavior of breathing with their mouth open while they're sleeping, and that can carry through the day. So it's a breathing problem. It's not a sleep breathing problem, which is why I think dentistry is getting away from this sleep dentistry kind of moniker and going towards this airway dentistry kind of thing. So the behavior part has to be addressed as well.
Exactly, and that's a big issue that I've had when I've talked to ear, nose, and throat physicians, that they've wanted to wait on the tonsils and adenoids removal. They say, oh, let's just wait, they're going to shrink. But a lot of times if we wait, it's too late. Because as you said, they've developed that open mouth breathing posture. And you can imagine if somebody is walking around like this all day, they're going to start growing like that.
Yep.
And what's going to happen is these children, these poor children, will wind up with long faces. And you'll look at them compared to their parents, and they don't even look like they're from the same family sometimes. I mean, it's just, they're very distorted.
The way your hands just went too, it just made me think TMJ problems. As their face is growing down and forward, they're putting pressure.
Well, they're putting
on the
pressure,
jaw
right,
joint
and if things aren't growing
stretching
properly,
the
they can
ligaments.
Exactly, they can have all kinds of issues like that. So we try to, if they're mouth breathing, the first thing is you got to get them to breathe through their nose. Properly through their nose, get the right carbon dioxide oxygen exchange. It'll help to decrease the bedwetting issues, help to decrease a lot of the other symptoms that these poor children are having.
Yeah, it's crazy. It's crazy how everything's so interrelated. So what is the role of the tongue? We kind of talked about it just a tiny bit, so can we elaborate on that? Is there such a thing as too big of a tongue?
Interesting question, Shirley.
Is it?
Interesting. In the past, a lot of surgeries were done on actually, they would cut the tongue. They would either take the tip of the tongue and make an incision, or they take the sides of the tongue, make an incision. And what they found is it, in fact, was not the tongue that was too big. It was that the mouth was too small. And you think about it, think about the tongue as a car and the mouth is the garage. You know, and the tongue has to fit in that garage. And if it doesn't fit in the garage, usually the tongue is not to blame. The garage is too small. So that's where the expanders come in. That's where you see these kids that come in and they put their teeth together, and the teeth are sometimes, you know, inches apart because their tongue is resting all the time between the teeth because there isn't room in the mouth. And there's really only a couple things, the two main things that make the arch develop out naturally is just the tongue up in the airway, the tongue should sit passively on the roof of the mouth, and every time we swallow, the tongue goes against the palate, which shapes the palate. Right. So if you have an open breathing pattern, the tongue's going down and forward, which is messing up the teeth and making your jaws grow apart. And the second thing is chewing. Chewing helps to form the palate, and it's hard foods. In our soft diet,
all these smoothies and all these blenderized foods, and it's really getting to be where we have formula for adults.
Oh,
they put powders into a thing, add some juice and add some collagen powder, and they add some of this and some of that, and they create an animal protein in a blender. And I could go on and on. It's a huge pet peeve, huge.
I agree with you 100%. It might be good for the body, but have natural protein. You know, chew on hard nuts. You know, chew on things that stimulate. Use your teeth. And that's why our generation, it's interesting, Shirley, when I started, it was all extract the wisdom teeth. Our jaws were so small, no room for the wisdom teeth. In 30 years, I have seen now cases where no room for the second molars. Not only the wisdom teeth, but the second, our mouths are shrinking.
Yep.
And they're shrinking because of poor airway, all the allergies present in the world today that we're breathing through our mouths, our tongues are dropping, our palates are collapsing, and poor eating habits. That's it.
Yay!
Poor nutrition.
There's so many things that interplay here, and it's just really crazy. The nutrition piece is a big missing piece. So how can early orthodontic treatment help with these breathing problems? I think we kind of addressed it a couple of different ways. Most importantly is expanding the arch to get the teeth to stick in there.
Exactly. You want to do that. And another thing that the advantage of bringing a child in early for early treatment is we can look for real problems in the mouth. One of the main ones, and this is becoming a field now that's exploding, is the tongue ties.
Oh.
You know, it's just that I think Mara has a couple pictures of that, the tongue tie things, and you need to have that addressed. When you said how early should these children be, I would love to see osteopaths in the birthing rooms.
Yes.
And I think they do that in South America. In South America, actually, when a child is born, if they have a tongue that looks like that, boom, the surgeon, without any qualms at all, boom, they will cut it immediately on the newborn.
Yeah.
On that. By having a tongue tie like that, the tongue obviously can't get against the roof of the mouth, so you don't get the palate formed, and the tongue tends to drop back a little bit, blocking the airway. It's horrible.
Well, and that's where that hyoid thing comes in too, that we showed earlier on the image. The tongue is attached onto the hyoid bone, and then it's supposed to be free. It's supposed to move around and do tricks like we were doing earlier. And what's happening if it's tied is that the hyoid bone is also then locked, because that's supposed to be moving around a little bit, and then it's pulling the curve of the spine, or the curve of the cervical spine forward, and so you end up with this chiropractic problem. And the number of nerves that come out of the cervical spine is probably innumerable for a dentist and a myofunctional therapist. There's a bunch of them. And it interferes in so many different ways. Just this last week, I was chairside cleaning teeth. I sub at a practice. I saw more tongue ties in this last week than I did, I don't even know, probably the last 8 months. It's crazy how things come in clumps like that. And these were adults, and they couldn't hear what I had to say about how the tongue tie was interfering. So this kind of conversation that we're having might at least get people alerted that this isn't just somebody trying to make some money for cutting tongues.
Not at all. And it used to be in the past they would only do the surgery to get rid of the tongue tie if there was a speech problem.
Right.
And they would have a certain way that you need to pronounce, like from 60 to 70. If you didn't do it properly, they would automatically then do the surgery. That's totally out of the realm now. What we are doing is finding these tongue ties are very, very bad for the patients. And there are anecdotal stories I can tell about other colleagues of mine that have had adults that have had their tongue releases and their TMJ problems went away.
What?
Their cervical, their back and neck problems went away because, as you said, with the hyoid bone attached, you develop this forward head posture. Imagine sitting, your head is like an 8-pound bowling ball on the top of your neck, and you're sitting there forward all day long. Imagine all the pressure there. They get these frenums released, and it's just day and night for them.
And when the chiropractors look, they say, oh, it's the texting, it's the texting. It's not only the texting, especially if it's a 9-year-old or so. It's not that. It's this tongue tie. So we could just go on forever and ever.
Well, I guess that, on this same subject, though, I had a patient. I think it's very, very important that, sure, people could go out now after listening to us and go to their dentist and say, I want this clipped, or what do you think? And you could have all these surgeries going on, but there's more to it than that.
Yeah, you need to know what you're doing.
You need to know what you're doing. There's all kinds of tissue attached to that little muscle down there. If you don't get that tissue released properly, things could actually be worse than when you started. And you need to have therapy before and after the treatment. And I've seen it firsthand because I've had a patient did very little therapy beforehand, had it done by somebody who wasn't really trained to do the frenectomies the proper way, and then she had afterwards did not do any therapy whatsoever, and things scarred up underneath her tongue, and she is worse off than she was.
Ugh,
you have to go through, and now you do a lot of that training, don't you,
That's
Shirley?
what we do,
That's
yeah.
what you do.
All this ADHD we've been talking about, the snoring we've been talking about, the tongue tie release we've been talking about, that's what we do at Primal Air. So we're out of time, so if you could please give your address and your website, and people can find you if they would like to drive all the way to Baraboo.
Thank you. Well, I'm at 880 14th Street in Baraboo. I'm just kitty corner from the Baraboo Hospital. And you can find me on the web at passionorthodontics.com. And thank you for this opportunity. I think just to leave everybody with something, the earlier these children are treated, the better. And if you sense something is wrong with your child and you're not getting that satisfaction, by going to your dentist or something, go to someone else then. Find somebody who can help you out. I've done that with ENTs, that I've said, I want the tonsils and adenoids out, and they said no, and I've gone to a different ENT.
Well, that's how you have to do it, I guess, sometimes. Thank you so much,
Thank
Dr.
you,
Paschen.
Shirley. I really appreciate it.
So this is Shirley Gutkowski signing off for The Spot for Health, where you can go to find out more about health and where to go for health in Sun Prairie.